Welcome back. In the last video, we went through the coronary arteries, the ECG leads, and how different infarct locations appear on the ECG. In this one, we will dive into acute coronary syndrome, its predisposing factors, the key symptoms, and how we diagnose myocardial infarction using both ECG findings and cardiac biomarkers. Acute coronary syndrome includes three main types: STEMI, NSTEMI, and unstable angina. In STEMI, there is complete occlusion of a coronary artery causing a transmural infarction, meaning the entire thickness of the heart wall is affected. On ECG, we see ST segment elevation, and importantly, troponin levels will be elevated due to myocardial necrosis. In NSTEMI, the occlusion is only partial, so it's a subendocardial infarction affecting just the inner layer of the myocardium. The ECG typically shows T-wave inversion or ST segment depression, and the troponin is also elevated here. Finally, in unstable angina, there is also a partial occlusion but no myocardial cell death which happens. That's why troponin remains normal and there is no ST elevation, only ischemia, no infarction. The main risk factors for myocardial infarction are smoking, hypertension, high cholesterol, diabetes, and central obesity. Stress and lack of exercise make it worse, and when several of these combine, the risk skyrockets. These factors are all linked to coronary artery disease. They gradually damage the vessel walls, leading to plaque buildup and narrowing of the coronary arteries. Over time, this can trigger an acute event like myocardial infarction. To understand the symptoms of myocardial infarction, let's first talk about angina pectoris. Angina is that characteristic pressure or tightness in the chest, often radiating to the left arm, shoulder, neck, or jaw, and it happens because the heart muscle isn't getting enough oxygen. Stable angina usually results from atherosclerosis, which is gradual buildup of fat plaques in the coronary arteries. The pain typically appears during physical activity or stress and disappears within 5 to 10 minutes of rest or after getting nitroglycerin. But when that plaque ruptures and blood flow suddenly drops, the pain becomes more intense and lasts more than 20 minutes and can even appear at rest. That's what we call unstable angina, which is part of the acute coronary syndrome. If the ischemia continues long enough to cause actual death of the myocardial cells, it becomes myocardial infarction. Now, the symptoms of angina pectoris and myocardial infarction might overlap, which are chest pain and shortness of breath. But in infarction, the pain is stronger, lasts longer, and doesn't go away with rest or medication. Patients often experience nausea, vomiting, and sweating, and may also develop arrhythmias or hypertension as the heart's pumping ability weakens. When diagnosing myocardial infarction, the ECG is one of the first and most important tools. In NSTEMI, which is non-ST elevation myocardial infarction, you typically see ST segment depression, which can be horizontal or downsloping. It should be more than zero point 0.5 millimeters in at least two adjacent leads. You might also see T-wave inversions, which are more than 1 millimeter deep, again in at least two adjacent leads. Now, when we say adjacent leads, we mean leads that look at the same area of the heart. For example, V1 to V4 cover the anterior wall, while leads 2, 3, and AVF look at the inferior wall. So the changes need to be consistent across neighboring leads to be significant. In STEMI, the key finding is ST segment elevation in at least two adjacent leads. The exact cutoff depends on the leads and the patient's sex. In leads V2 and V3, the elevation should be at least 2.5 millimeters in men under 40 and 2 millimeters in men over 40 and 1.5 millimeters in women. In all other leads, an elevation of 1 millimeter or more is enough to diagnose STEMI. Remember, if the patient has left ventricular hypertrophy or a left bundle branch block, the criteria differs. Those patterns can mimic ST elevation, so interpretation needs extra caution. For posterior infarction, it's a bit harder to see because the normal ECG leads don't look directly at the back of the heart. What we usually find is ST depression in the anterior leads, V1 to V4, more than zero point 0.5 millimeters. And if we place extra leads on the back, V7 to V9, we will see ST elevation over zero point 0.5 millimeters, and that confirms a posterior myocardial infarction. In patients with left bundle branch block, things get tricky because the ECG already shows strange patterns. Normally, in left bundle branch block, you can see some ST elevation in V1, but the QRS complex is pointing downwards, which makes it hard to know if it's a real infarction or just the bundle branch block pattern. That's why we use the Sgarbossa criteria. Basically, if there is a sea elevation in the same direction as the QRS complex, it leads like V4 to V6, also 1 or AVL, or ST depression of 1 millimeter or more in V1 to V3, or very strong ST elevation over 5 millimeters, it suggests there is an ongoing myocardial infarction. Now, ECG changes help us identify a myocardial infarction early, but to confirm the diagnosis, we always look at cardiac biomarkers, especially troponin I and troponin T. Both are highly specific for heart muscle damage, and hospital usually measure either one depending on the lab method. They are checked when the patient arrives, then again after 3 and 6 hours. And if the levels keep rising, it strongly indicates a myocardial infarction. We used to check CKMB, but it's much less specific and not commonly used anymore. So, to summarize, acute coronary syndrome includes unstable angina, NSTEMI, and STEMI. The main difference is that STEMI, ST elevation myocardial infarction, shows ST segment elevation and elevated troponin, and STEMI, which is non-ST elevation myocardial infarction, has no ST elevation but the troponin is elevated, while unstable angina shows no ST elevation and normal troponin levels. Diagnosis is based on ECG findings and cardiac biomarkers. If both point toward infarction, the next step is coronary angiography to locate the blockage. And if needed, we can use a PCI, a procedure where a balloon or stent is used to reopen the artery. In the next video, we will go through coronary angiography, PCI, and the overall management of myocardial infarction. That's it for today. I hope you enjoyed the video and peace out.